first of all, I wanted to say for those who are wanting to get those continuing education for that participation in today's training, I'll share a link for our survey at the end of all of this. And so with that, it is my pleasure to introduce to you Stacy T. Garden. She has MS, CRC, and CIPS. Stacy is the IPS lead state trainer for the Wisconsin Department of Health Services through the University of Wisconsin-Madison Department of Psychiatry. She holds a Master of Science degree in Rehabilitation Psychology and has been working in the behavioral health field for about 20 years. During this time, she has held a variety of positions, including job trainer, line therapist, community support specialist, clubhouse generalist, employment specialist, and rehabilitation counselor. Being from and living in small town Wisconsin for most of her life, and then living near Denver, Colorado for over a decade, she has experience in both rural and urban settings. Stacy is also a combat medic Army veteran, a certified rehabilitation counselor, and previously a licensed professional counselor. She has served on many boards and advisory committees for initiatives including behavioral health, employment, and education in youth, and is very passionate about recovery, early intervention, and improving the quality of lives for all people. So thank you for being with us, and I'll turn it over to you, Stacy.
All right. Can everyone hear me okay? Okay. Thank you. You read the long one, Felicia. That was embarrassing. So thank you for that introduction. Yes, I've been doing this work for quite a while. I love it. I'm passionate about it. You'll probably hear that is evident throughout my discussion today. I'm a pretty informal presenter. I've been training on IPS since 2014. And when I first started, I never used PowerPoints, never did the virtual thing. So it was a lot of discussion back and forth in person. I try to continue that on as much as I can in this kind of setting. So unfortunately, today I'm in a hotel room, so I don't have two screens. So is it Felicia that will be, or somebody checking the chat for me, maybe? Okay, so questions throughout, feel free to pop, I don't, get off mute or go in the chat, interrupt me as much as you can or want to. You don't have to wait till the end. I just want things to be fresh and a conversation. If you want to put your cameras on, great. I don't know that I'll be able to see all your faces anyway, so, but because of the one screen thing. It is nice to kind of just see kind of reactions and get the feel for the room as much as possible. But I also understand, and I'm off camera often myself, so do what feels comfortable for you. As far as accommodations, does anyone have any need for the like showing captions, or was there any need for ESL interpreters or anything? I should have probably asked that prior to this meeting, and I'm sure you guys had that all already asked and figured out, right? Everything's all okay there. All right, head
Yeah, I
nods. Good.
believe we're okay. Thank
Awesome.
you.
Yeah, okay, so I will get started then. I'm going to just share my screen. Let's see. Yeah, let's just do that. Okay, does that look good for everyone? All right. So I'm a visual person and don't always learn auditorily. So I did enable captions just for people if they'd like to follow along. I will try to talk clearly so that it doesn't have a lot of, weirdness in the words. But so this is kind of a typical IPS 101 PowerPoint slide that we've adapted through over time, added things, and we take out, hide slides. As an IPS state trainer, we kind of utilize a lot of the same slides, but focus on certain conversations. So today, I'm really going to focus on how we use supported employment as a recovery-oriented service. The Wisconsin state team consists of me, Alexa, and Teresa. Alexa Nobis is our policy analyst who works with data and more of that policy work where we're trying to expand statewide and that sort of thing. And she does a lot of other things besides IPS on her plate within Division or Department of Health Services, Division of Care and Treatment Services. And then Teresa and I are actually contracted workers with UW-Madison, but we are housed within DHS, Department of Health. So we're all a team with that population of staff. So why is employment a critical behavioral health intervention? Why we're talking about this today is that, right? We know that employment helps with all aspects of our health, and it is considered that critical intervention in social determinant of health. We're going to also talk about the what today, where employment is used for prevention, treatment, intervention, and recovery. So not just used as a recovery support service, but also if we're using employment in general, we're touching all aspects and all the continuum of care. IPS is used typically after someone is diagnosed, so it's not that primary prevention piece. But if you're thinking just employment in general, it could potentially be that that piece as well. And then the how. So we'll really dig in and using tools. I'll go through quickly kind of the beginning of the slide since I know a lot of you already had the IPS 101, and we'll dive in a little deeper in this how section of really using the tools, showing you some tools, and then do some scenario-based practice with time. So I always start off with this, the intent. I mean, you might have seen something similar before. When I'm in a big conference of, 100 people or more, I'll have everyone stand up in the room so you get that visual. And I say, okay, pretend every one of you have been diagnosed with a severe mental illness diagnosis, whatever that means to you. You all have this label, this challenge in life. Most likely, majority of us have experienced some sort of behavioral health diagnosis or experience in life. And I think I've even heard something about 100% now has had some sort of mental health or substance use now since even COVID. So thinking about that, everyone in the room is standing up, and 2/3 of you want to work, right? So maybe a third of you sit down. So 33 of you, if there's 100 in the room, can sit down. So majority of the room, 67 people are still standing, and they want to work. They have this diagnosis, and only 20% of them are sitting. And my math is ridiculous. I should always have this written down, but maybe 20% of that 67. So 5 of you or 10 of you or whatever sit down. So still, majority of the room is standing. You're not working right now, but you want to work and you have this diagnosis. So 41%, so still almost half of the room, 41% is standing, struggling to kind of figure out what to do with their life, right? Only 2%. So one person, one or two people of this 100%, 100 people in the room. So you over there, one person can sit down of 100 because you want to work, you have this diagnosis, you have access to services like IPS. So still, that's so many people, 41% are standing that want to work, that don't have this opportunity. So thank you for those of you here today for doing what you're doing to increase that 2% of supports for people that need it and want it. And I do also want to just make a point to, this 37% that say they don't want to work, that came from a survey a while back where there was, I don't have my notes in front of me, but that's I think 60, treatment centers, inpatient center, there was so many different day programs, inpatient, all sorts of areas that were interviewed, and the people with that diagnosis were asked if they'd like to work or not. And so that's where they came up with that number. So it was a lot of different settings, all with people with that severe mental illness diagnosis. And my assumption is the people that said they don't want to work typically have maybe even tried in the past, didn't have the supports available to them, feel like it's a failure maybe, or they're too stressed, or they're told not to work, or they can't work because of benefits or other situations, or maybe they're told that they have too severe of symptoms, or they think themselves that they can't because of certain stigmas out there. So with conversation and with this support, I do think that that 37% eventually, if you keep asking, and that's part of that IPS fidelity, that asking about interest would change eventually to, yes, I do want to work. It's just at the moment, time and place, they said they didn't want to work. I promise I won't talk that much on every slide. So for just an initial discussion to get you guys thinking, and you can put it in the chat, you can think about it, you know, you don't have to say it out loud if you don't want to, but just kind of thinking about work in general. What is your work experience for yourself? Have you ever been underemployed, unemployed? Do you know someone who's unemployed or underemployed or have been? Kind of what thoughts did they have when they were in that situation, or did you have if you were in that situation? And then thinking about what was your first job and how you got there. I have this almost exact presentation coming up at 1 o'clock here at the Substance Use Mental Health Conference here in Wisconsin. It's almost 1,000 attendees here, and I think 100 people or so responded to my poll so far online for the question of how many jobs have you had in your lifetime? And I think it was average like 25 so far. So thinking about that, like that's a lot of jobs that someone had in their lifetime. But I think it was between like 6 and 50 or something. And so thinking about when we work with people and we see a whole list of job experiences, sometimes we're like, oh my gosh, they jump from job to job, or like, is that our assumption? Or if we don't see any jobs on here, what are we assuming when we're talking to people and working with people? So just kind of think about that when you first talk with people. And then think about what do you see as the benefits of work? What benefits you? Like if you didn't work, how would your life be different? How does work make you feel? And knowing when you don't have that purpose in life or something to do or something to wake up for in the morning, how it affects your day and your life. And thinking about how, I mean, we even know through some of the research and information we got through the COVID situation and that pandemic was so much more isolation, substance use, with unemployment and underemployment that came with that. And we know the benefits that having work and having something to do can increase mental health. And I think if you have that serious mental illness or some sort of mental health or substance use struggle, how it can exacerbate those feelings and thoughts tenfold. Anything in the chat or anyone want to kind of mention to that discussion or thought? Anyone have thoughts after just thinking about those questions?
Hi, this is Terry. I have a couple thoughts of this discussion. So I think, thinking about people that, jobs, it does give a sense of purpose and meaning. Years ago, I lost my job around 2004. I was working in finance and they did company cutbacks and I was cut out of a job. And it was kind of abrupt too. They just kind of came in and said, okay, we have to do cutbacks. Sorry, you're let go. And it was immediately that day. So it was a blessing in disguise. However, I wouldn't be where I'm at if that didn't happen. But at the time, though, it's like, well, what's my next step? What do I got to do now? And of course, I have good coping skills. I know what to do to make myself well and get myself into a good place and move forward. But if somebody doesn't have those that toolbox to kind of maneuver through, it can be very daunting, very, very hard. And I think even just in the chat box here, and even in post-COVID right now, even during COVID, I think a lot of people, there was a great resignation. A lot of people left their jobs, and some people never went back to them. So.
Right.
I think it does, I've worked in behavioral health for over 13 years. And I think one of the things that I've never noticed in anybody I've ever seen come into the office and I've treated before, it's always, sometimes if they don't have a job, you don't have access to those resources. Well, I don't have housing. well, I'm not employed, I'm living with family members. I mean, having a job does give not only a sense of purpose or meaning, but also at the same time allows that person to start functioning independently. And then therefore, person's going to do a lot better. So I think having, those supports with IPS and just in my short, knowing a little bit I'm learning about IPS is I just think it's amazing that people, get that support to help them guide them in that toolbox so they can get steady and competitive employment. So that's kind of my thoughts on the discussion. Sorry if I went on a rant there, but just wanted to share a couple things.
Yeah, no, that's great. Thanks, Terry.
Stacy, I wanted to just kind of piggyback and add on to that because in pre-COVID and in a lot of work I've done in this area, one of the leading causes of depression and depression disorders is employment. And in fact, I think there was a study a while ago, and I'm not going to be able to quote the source, but that 3 months of unemployment is almost a guarantee of a depressive episode or disorder, especially forced unemployment.
Yeah, absolutely.
On choice. Yeah. So anyway.
Yeah, thanks for that statistic. I think it's so important to see those correlations. And there's so many studies about employment and happiness and employment and unemployment, even underemployment that depression or those diagnoses of anxiety. And they say that you think work is stressful. I think it was like Mark Sanders, maybe. I can't remember who this quote was from, but it was, you think work is stressful, try unemployment. And yeah, I think it's just thinking about that, like all the things that you have to go through, not having that sense of contributing to society or sense of who you are. Identity changes so much. My husband allows me to share this story, but he was a mayor in the Denver area, and he had all these aspirations and goals and connections and networking. And then I drug him to Wisconsin, and he lost all that. And then COVID hit, and he was like a waiter, and he now works at a warehouse. And he's like, you can just see like the identity shift of him, and depression sinking in, and substance use increasing, and all of these things, because he's like, I am not this person anymore. I'm totally different, and the identity just changes. And so how do you help somebody see value and see worth in themselves, and by helping them with it doesn't have to be where you were at or where you think you could be or should be right now. It's let's see where you are now and what you feel like you can contribute to. And now he's worked his way up to sales, and he's doing great, and he's being politician sales, it works out pretty well. So kind of thinking about his value and worth within the company, and he's being seen now. And so how do we help people identify that worth? Luckily he's had like me and other supports and coworkers that lift him up, and friends, and some people don't have that support. So you're the support for that person to kind of make them see who they are and that worth, and to take those risks instead of saying, "Ooh, let's wait. I don't think you're ready yet. Those symptoms are too severe right now, or your substance use is too high." And looking at employment as that way to recovery, and that we're using employment as that therapy, as that way to change life, instead of waiting for life to change when we know employment's what changes the life. Okay, so so there's a couple quotes. I just like to show the one I recently in 2021 we had our first time kind of coming back together in person. Lisa Dixon is the new IPS International kind of director over the New York State Psychiatric Institute that houses IPS now. And she said in the conference to everyone that IPS is a valuable human and humanizing global practice. And I just think that's so important to like know that you're a part of that. It is so valuable and so human and so humanizing. So just stressing that one, I think, is so important too. Not only an effective short-term treatment, but also one of the only interventions that lessen dependence on the mental health system over time. And there's research that show, people using IPS and getting employment reduce their need for mental health supports. All right, so I'm going to move this bar on top because I can never see the top. So why now? So this is the why, right? Digging in, we really want to focus on that being that critical social determinant of health. We already talked about, the benefits of employment. We thought about, how it improves self-esteem, but not just giving people purpose, improving quality of life, all those things, but also assisting them with tools like financial gains and ability to, get resources like housing and so forth, which again can contribute to increased self-esteem and decreased, mental health symptoms because I can pay for my own rent. I can pay for my own food. I can do this and support somebody if needed, that sort of stuff. Okay, so another couple quotes and just talking about labels too, thinking about it when somebody identifies themselves as homeless, mentally ill, I was called a welfare mother, what does that look like to somebody? And then when they do start working or get a job or even going to school, my titles have changed. My identity has changed. A financial administrator, college student, working mom. Like that's so different. And just a side note, I don't know that working dad is really a thing. So just thinking about that out there, just throwing that one out there. But thinking instead of like welfare mother, working mom, it's such a different identity and label for yourself. How does that make that person feel? How do they view themselves? Not only how do other people view them, but how do they view themselves? And how does that affect their mental health? So then the what? What is IPS? So IPS is the way that we do all these things, help support people get to this employment, right? It's a evidence-based practice. You already know all this stuff. 28 randomized control trials. It's all proven. It's all those things. If you want me to dive into more of that, let me know. Otherwise, I'm going to keep going. Part of this international learning community. We're growing all the time, 26 states and regions now. It's all over the world. We have 8 countries currently contributing to the learning community that kind of comes together every other month. And then we do have like trainer monthly call or every other month and fidelity reviewer calls. And we learn from all over the world. Not only are these 8 countries involved in like data reporting, but I think there's something like 19 countries that actually utilize IPS. So even outside of the learning community, there's people we can connect to. And then in IPS, in Wisconsin, particularly, just to kind of show you how our state is connected, and it's different than a lot of states in Wisconsin or in the nation. Wisconsin is a county-based system, so each county has their own behavioral health program, and then they typically contract out to a vocational provider. Some of the vocational providers provide just for that one county, and some provide for many counties. And then in larger counties, like in the Milwaukee area and Dane County, which is Madison, we have multiple vocational providers in one county. So it kind of is switched in different ways. It's not regional like most counties or most states, but just kind of partnering is really the point of this slide, that partnership where we're really all communicating together and making sure that it works. Right now we have 25 counties. I think I'm just now implementing in Waukesha. I think we have 2 others in conversation. Many more that are interested, but there's only Teresa and I, so we're slowly implementing and trying to get statewide. And our employment rate, I think, is closer to 44 right now. That was 2022. So you guys already know the practice principles. We're really going to dig into the zero exclusion and the integrated services, I think, today. Is that what are those the 2? Okay. Thanks, Alicia. That's what I'm going to also be doing at 1 o'clock. So that's awesome that it's kind of the same. So zero exclusion, as you know, it's really based on if someone wants to work, they're eligible for the program. We don't consider any other situation in their lives, homelessness, legal system involvement, whether they have behaviors that might be, oh my gosh, an employer would never hire someone like this. Like these thoughts of let's just wait, let's just see, let's get them sober, all these outdated thoughts. We don't consider those anymore. This is all if someone wants to work, it's our job to help them figure out and work with them on what supports they're going to need to be successful. And we know everyone can work in some level, some degree, some type of job. There are some strengths and, really, really good things that people have that, sometimes it takes some digging to find, but we will find them. A lot of times they're out there. Oh, this person's really social. This person is this and that, and we really have to try to let those things shine and not let those barriers and other things outshine it. For treatment teams, this can be really hard too. I like to just bring this up to when I do clinical trainings to treatment teams and providers and clinicians that refer to the vocational provider, the employment specialist. A lot of times they're just very scared to refer. They're like, oh, we've done all this work. We've worked with this person. They've tried to work before and they've gone back a million steps, right? Like it was too stressful. It was this or that. And I think it's just really important to talk with the clinician and the treatment team and the referring people, prescriber, whoever's referring, whoever's part of that treatment team, and just have conversations. Learn about what their supports are. Build that rapport like you do with your job seeker. Build the rapport like you do with an employer out in the community. Set a time, just meet with them one-on-one and get to know them, get to know their job, build that rapport so that they can feel like it's a little more trustworthy to like refer to you and say, okay, I think I can, what is it going to hurt? It's not going to hurt because we're here to help them find their dreams, passion, whatever, something to do, get them off their parents' couch, whatever it is. If they're bored, just try it, refer them to me and see what happens. I'm here to support. We can always refer back to you, or you're going to be with them too. It's not like they're losing the treatment team support by referring to this employment specialist. So having these conversations, I always try to challenge the ones that like don't refer at all or refer very rarely. Give me your hardest one, and I know that's like horrible language to say, but somebody that you don't think can work, just give them to me and see what we could do, if they're wanting to, of course. And so thinking about when that happens and they see that person succeed and whatever that means to that person, getting a job, going to school, whatever they're even working on those goals, that referring clinician then all of a sudden goes, oh, this is great. Like they're more med compliant. They're more, whatever their clinician language is that, they're coming to my meetings more. They're really happier. They're smiling. All these languages I see over time, and sometimes it takes a year or two, but just try, just ask, just send them to me, see what happens, and then go from there. And I think over time, too, referrals will start increasing, and the whole team will be bought on board if they're not already.
I think that's a really great point because it seems like you can always see kind of the like silent writing on the wall with who buys into zero exclusion and who doesn't,
Yep.
just by seeing, like you mentioned, who's referring and who's not, and really reaching out to those people who might be a little apprehensive.
Yeah, and what we've started doing, Milwaukee does a really good job of it, trying to do it a little more statewide, but asking the clinical supervisors, like if we can get one of them in an interview during the fidelity review and ask them, do you track like who refers and who doesn't refer and who refers more and who refers less to IPS? And if they don't, try to get them to track that as a supervisor, and then maybe encouraging those people that aren't referring, and having those discussions and try to get them to have like a goal to refer more, because there might be reason. Usually I hear, well, they have got a lot of people that are older or younger or really severe, and that when I hear the really severe, I'm like, oh, those are the people that need to be referred. Let's refer them. Let's talk. Those are the people that obviously, like if they're stuck or they've been in this situation in services forever and they're not moving forward and they haven't tried IPS yet, do it. It's gonna help them. Almost, in my opinion, 99.9% of the time, it'll help them. With integrated services, so it goes hand in hand, right? We're talking about zero exclusion and referrals and working together and communicating. It's not a siloed out program. And that's what's so crucial about having that employment specialist sitting in on treatment team meetings, being a part of that team, contributing to solutions, talking about, the person, hey, today I saw Johnny and this happened, or this experience, or he shared this with me. So we can all be on the same page and move forward. If we're not, they're going to hear different things from that treatment team member. Those people on the treatment team might say, oh, I know you're working with your employment specialist, but let's really focus on this treatment, or that treatment, or let's wait a little bit. And like, even if they're like, yes, I made the referral, sometimes in the back end, their voice might not support that goal. And that job seeker can tell when my clinician really doesn't think I should work yet, or my med prescriber really thinks I should wait until I'm more stable, or whatever it is. And so when they don't fully believe in their heart that this person can work, they're gonna, like, people will just, it'll come out. Maybe people are good readers of other people, and job seekers see that and know who's supporting them and who's not, and who believes in them and who doesn't. So when our treatment team is all over the board on who's really supporting or believes that they can work, it's hard on that job seeker. So the more that employment specialists can be integrated and talk about the successes in a treatment team. Hey, I know Johnny's referring, and I know he wants to be a rocket scientist. I just want you guys all to know we met today. He showed up. That was the first, like, on time or whatever. So like little successes even can help that team go, oh wow, yeah, he's making these advances, and maybe I shouldn't, support this goal. I do see progress being made. Lots of examples as far as integration. If you can get face to face with them again. I know this day and age, virtual is more often, or phone calls. We're not always in the same space. If you can be in the same space, that is part of fidelity. If you're shared space or office space or whatever, and can see them at least, weekly, I think would be helpful. But it's not always that hallway passing and conversation like Fidelity kind of mentioned anymore. So thinking about how else can we get the intent of that Fidelity item if we're not getting that face-to-face? Can we find other opportunities outside of even the treatment team meeting to connect with the treatment referring people? Can we make sure to just touch base, emails, phone calls, updates in between, throughout the week on the mutual people? And then, of course, the shared case notes. If you have a shared integrated record, a lot of states have, the employment specialist a part of the agency, so it's just a part of the records. The EHR system is shared, but like states like Wisconsin, where they're contracting, not all counties will give permission for their contracted vendors to utilize that EHR. So like more conversation then is going to have to happen in different ways. All right. So this is kind of the main thing. We still have, what, 20, 30 minutes or so, right? Okay, so this is a worksheet. I don't know if who here like put a little emoji up or nod your head or something has seen this helping individuals consider employment worksheet. Has anyone seen that before? Let's see if this link works. Are you seeing the worksheet or still the PowerPoint? PowerPoint, okay. I'm gonna share again. So this worksheet is something that I encourage to share with the treatment team. And even just having conversations, if you get someone referred that's like pre-contemplative, or like maybe like one day wants to work, one day doesn't want to work, or showing like the back and forth. I think it's just so important for like the actual treatment team people, and when they're having conversations initially, even prior to referral, to go through conversations. And this worksheet can help facilitate that conversation if they're struggling with like, how do I talk with someone about work? It shouldn't be just a, do you want to work or not? No, okay, cool. That is so easy to just bypass, like, especially when that clinician's like, yeah, I don't think you can work right now anyway, in their head. So when you can get them to say, here's a tool, here's something to help you encourage conversation around work. And knowing that maybe today they might not want to work, but after some time they might want to, and how important it is for them to want to, and then get that referral in the future to help their mental health and or substance use. So it gives some tips. I'm not going to go through the whole worksheet, trying to encourage the person, being curious, kind of giving them, again, helping that clinician really feel like I can have this conversation. The next steps, what are we going to do after this answer, after this conversation? Should we schedule a meeting with an employment specialist? Do you want to learn more? Maybe your benefits are affecting. Do we need to schedule? So again, it goes through kind of some options there. And then tips for talking about work on an ongoing basis. So, okay, next week, maybe they said yes. So now I'm going to say, okay, what do you think your dream job would be? And kind of start those conversations. So you really know, or that clinician really knows kind of an idea about their history and information of what they want to do even before referral can be helpful for that treatment team. And just also for that job seeker to know somebody's actually asking me of what I want and what interests I have, which is just huge when nobody's ever asked them that before, because somebody, might never have been asked before because nobody ever thought they could work. So um, a thing that's hopefully being changed in the school systems is really trying to get people with disabilities and the emotional whatever diagnosis when they're young, that they can be asked about what they want to do regardless of those labels. So those are the questions to facilitate conversation, but really the worksheet piece, to document that conversation. So what are their hopes? What are the concerns? What assistance maybe they want to have? And this, you don't have to be like, do you need help contacting employers? Do you need help finding? It's more of like after you have conversation, like we do the career profile. You're thinking, oh, you didn't like calling employers before you going there. Okay, so then maybe that clinician will be like, they might need help contacting employers. So just through information and conversation, that clinician might get some information there to help with that referral. And then this is really where that like motivational interviewing kind of readiness ruler comes in, where if you've ever taken motivational interviewing or know anything about the readiness ruler, it's kind of that similar thought of like how you rate something first, like how important would a job be to you? Well, 2, no, I don't want to do that yet. Okay, well, how confident would you be that you'd be successfully employed? Oh, 1, definitely. Okay, well, then next week you ask them, how important is the job to you? Well, actually, I thought about it and it would be really cool. It would be important. So maybe a 5. How confident? 3, and so you kind of start seeing, well, why is that? The readiness ruler kind of goes more into like the whys. Why did you rate it that way? And how or what could we do to move that up 1 more point? So again, kind of just getting a sense of where they're at. Maybe is it increasing? Why is it not increasing? And how do we get it to move forward? You don't have to be a 10 to refer. It's this conversation of, well, if this is really important to you to get a job, and you're not confident, do you want to just maybe talk to an employment specialist and just see what supports are available? And then after that conversation, ask again, well, now I'm a little more confident because I know that I'll have some supports with resume writing, which I was nervous about or whatever. And then asking too, like, well, when would you like to look for a job? If they're not, wanting to in the next year, that's even fine. I say refer. That employment specialist can help working with them. They don't have to start applying to jobs. They can just talk to employers. I find a lot of people who are in that ambivalent, it's all about that fear. And when an employment specialist talks to an employer, learns about what their needs are, brings it back to that employer, even if they don't, or that job seeker, even if the job seeker doesn't have disclosure, that job seeker is going to think, wow, that employment specialist actually cares about me. They talked to an employer on my behalf. They brought me information. And that does kind of sound like something I'd be interested in. Huh. And maybe, that employment specialist says, do you want me to introduce you to, you don't have to apply, but do you want to just meet the employer? They're really wanting to meet someone that might be interested in this position. It's no stress, like let's just talk. We don't have to apply. And a lot of times they go, oh my gosh, like that actually sounds like a good idea. Maybe I will apply. And so just having that conversation and getting them out in the community again, which is part of Fidelity, that 30-day talking to employers right away, once you start meeting with someone, is going to help the confidence about wanting to actually start applying for jobs for people. So then you can write out a plan if they want, and you don't maybe have to sign it or whatever. This is just a tool to share. You can adapt it however you want. But I like to share that one with clinical teams. So if you do meet with treatment teams, regularly and they are struggling to refer, and even not, this is a good tool to just share with them and good to evoke that conversation about the importance of employment regularly, especially with new staff and turnover all the time. Okay, yeah, and this worksheet is available on ipsworks.org in the library. You can always find tools there. There's lots of tools there. Just type in the search engine anything you're looking for. Sorry I didn't make it full screen. I'm just looking at the chats right now. I will send out everything to Felicia after this. Okay, so back to presentation, and I will share again. Okay, can see the PowerPoint okay? All right. So I talked a little bit about motivational interviewing. Yeah, okay, so we don't really say like motivational interviewing is like this huge thing. It's another whole evidence-based practice and process, and there's a lot to it and a lot of time to actually get an expert in motivational interviewing. But thinking about like different components and pulling out like stages of change. So when they're not thinking about work versus maybe, and then preparing, okay, we're going to start the process, actually action, actively job searching, getting a job, and then we got a job and we're in maintenance. This is a stage of change, obviously, in the employment world. Knowing that it can always go back to like, oh, that experience was not great. I'm gonna not work right now, which is so important. Again, so part of fidelity is to come back and talk to that job seeker right away and say, oh, that opportunity didn't work out, but I'm still here to help figure out what those lessons were, that why it didn't work out, right? Like we're here to help you get a better fit. Obviously, there was some reasons why that wasn't a good fit. We all had those experiences, right? Or probably will in the future if we haven't yet, where we're like, okay, yeah, that was not a great job, or there's components of it that I hated and I learned from it, and now I got a different job that is better. And so like that poll I put out, there's so many jobs that people have, and that's what we learn from, and that's what we grow, and that's the process that we want people to go through, a competitive process of work. And if this experience is not great, that's fine. Let's appropriately quit. Or if you got fired, okay, we'll figure it out and we'll apply for the next job that'll be a better fit. Let's figure out what supports weren't there. Maybe did you want disclosure for the next time? Bringing up that component of fidelity, right? Like do we want to talk about disclosure again? And maybe just for the next employer, not all employers, but maybe the next one, I can talk with them and advocate if you need any certain accommodations that might have helped or whatever. So just knowing this process, like we're not trying to get someone a job that's going to be a perfect fit right away. That's not a competitive process. It would be great and it can help, the more we do the job development, that systematic job development out in the community, and talk to employers and learn on both ends, really utilizing the career profile and really doing that second cup of tea, talking to employers and learning about their needs, we can make better matches. But it's not always perfect, and people will lose jobs and need to be encouraged that they can get a better fit, and we'll be here for them and to help with those support needs. And then, so in Wisconsin, we tried a pilot program last year with a lot going on. There wasn't a lot of interest, so we're going to try to launch it again next year. But in the meantime, we have a practice profile that we've shared with supervisors and employment specialists, and we've really been digging in on a lot of these ORS skills. So a piece of MI, a piece of motivational interviewing, but the ORS plus I is actually informing as well. So asking about, do you want me to tell you this? What do you know about this already? And are you okay with giving me a suggestion or giving you a suggestion? So informing is another piece of motivational interviewing skills that we really focus on. And we're trying to, integrate these ORAs plus I skills within IPS and really give employment specialists these tools to help dig this information out with employment specialists to talk to job seekers, to talk to their clinical teams, right? We want to build those relationships and use these open-ended questions, affirmations, really build that rapport. But then also the employers out in the community. How do we use these skills? Thinking of an employment specialist as a clinician almost to like say, hey, we're wanting to know about you and what your needs are. These skills really can help pull that stuff out. So that is just something I like to show and encourage you guys to dig into a little more if you haven't yet, and give your employment specialists a little more tools for when they're having conversations. And then with everything, we make sure we really discuss diversity, equity, and inclusion in all the work that we do. In all our trainings, we've added slides around these topics because they were missing, right? Like we know DEI, diversity, equity, and inclusion is integrated in the DNA, if you will, in all the things, but it's also really important to just make note that we are adhering to all of the, you know, inclusiveness and diversity. And when you guys were doing your report out, right, like I heard a lot of, you know, we have these statistics, we have this demographics of who we're serving, these populations, you know, male, female, races, all these things. And I wonder to like go a step further, if you're not already, digging into who's in your area of service. So does a certain county or the agency or in your state or however, you know, wherever your reach is for that employment team, what is it in the community? Is it majority white in that community? And if so, does that match that the people served? Is it, there's actually a really big Hmong community in certain parts of Wisconsin. Are we serving this higher population of Hmong in that county? Because, you know, are those percentages matching up? And do we need to make a goal to reach out to certain populations that aren't being targeted, or maybe aren't being as inclusive or included in services? Do we need to make sure to print out language information, or make sure that our information is more equitable for that 5th grade reading level? You know, all these things. And there's a DEI tool that we can share with you if, you know, in the future, if you want to dig into that kind of stuff and make goals for your IPS teams. But really just kind of making sure we're talking about cultural awareness in career profiles when we're talking to our job seekers about setting goals. And all of these conversations really come to in the treatment teams too, and their buy-in as far as, you know, we're adhering to this person just doesn't want to work on Saturday or Sundays because of their religious obligations or their identity of being a really big sports fan. And I had one guy that just wouldn't work Sundays because he had to watch his football. Found that out like 8 months later, that was the reason he kept denying jobs. So like if we're having these conversations of what kind of what do you identify with as is, you know, your culture, your identity, and making sure that we're matching that up in the community, we're going to get more treatment team people, more job seekers, more employers to believe that we're actually trying to make these good matches, and everyone will be all supportive, and it will be a good fit for our job seeker. There are a couple success stories that we could share. We need to add more because there's more all the time. But if you wanted to see any from Wisconsin, you can click on those links when you get this PowerPoint. But I just kind of wanted to make sure we had time for questions. So we've got about, what, 20 minutes for any kind of question answer. I talked fast. Yeah, let's open it up. I guess I'll start with a question. Do any of you here have challenges within your treatment teams of people referring? That is a closed-ended question, so a yes or no is appropriate here. But if you want to continue talking about the why.
Definitely.
Yeah, Amanda.
Yeah, we do have issues with referrals sometimes, and sometimes a lot of it just boils down to like the busyness of those mental health teams or VR counselors and things like that. Other times, I think it's some of those like preconceived ideas of work appropriateness or work readiness that we fight against still, I think. That broader, like somebody is not mentally stable yet, or there's a little less stability, and so they need to focus on that versus work. And so that's just an area that we continue to try and educate in, and have more discussions about how work can improve mental well-being, mental health, emotional well-being, and those kinds of things. So Yeah, it's a continued issue.
Yeah,
And
and I
so
think it takes time, right? Like especially for new programs or like big turnover programs, you're always going to get people that have those preconceived notions of like, well, they need soft skills and they need maybe a volunteer job first, and like all of these things, that stepping stone approach to like, because we just want to help people like feel comfortable. We want to be, we're care workers. We want to make sure that they're going to be successful, but like, yeah, like you said, education on like failure isn't failure, it's lessons learned. And we all go through these lessons learned to find good job fits. And this is a competitive process. And why are we othering the people we work with into a different process when that's not going to help them? So yeah, good point. And just encouraging again, just refer, just try the more referral and then they see that it works is really the most education that we can do and the way it helps the referrals increase. So we can talk and talk and talk like I do, and it'll go through, in one ear and out the other. But when they actually see the people they refer changing their lives, then that's when they start referring more.
Mindy wrote in the chat here. I think when we first started, we saw some struggles in that area, but over the last 2 years, we have seen a huge increase in referrals from our prescribers, therapists, and IHH team.
Yeah, 1 to 2 years is always what I see. You can see that change, that culture shift, the philosophy change in an agency or the team. They just start believing in it, like, oh yeah, duh. Like, why didn't I think about that before as like a treatment instead of an afterthought? Yeah, employment as a treatment intervention. The keynote speaker to this conference I'm at today was really talking about how um, when people go into like inpatient substance use treatment or they're in these settings, um, maybe a non-competitive employment setting or volunteer where they're like having purpose and they're doing things and they're getting clean and sober and they're like changing their lives or in prisons, they're getting these degrees and even a law degree and like doing really well. And then they go back in their communities and they have families and friends or the environment that is the same as it was before they went in, and they start using again or they go back to their old ways, and depression comes back and all the things. And so how can we make the environment and the community the place where, what did he call it, like the forest, of life or whatever, where that can grow and help that person flourish versus going back to that toxic environment. And that's what we're doing here, where we're helping somebody in the community find purpose and connect them with the healthier connections that we can hopefully get that. I heard, success story where they're making friends at work. Like that was great. Other thoughts on, I guess anyone struggling with like getting connected with like prescribers or the clinicians, like just even making those connections and trying to build that rapport, that you need strategies for that.
One of the things that we kind of see here is, most of our employment providers are separate from our mental health providers. So that seems to be kind of a challenge, just to be able to get invited to those meetings, and
Yes.
instead of trying to create our own, so that at least
Yeah.
we're doing our part to try and collaborate with our mental health partners. But yeah, we've got one of our pilot sites who started in 2019, just recently was able to kind of crash down that barrier and get invited to the mental health team meetings after having, their own for so long. And so, I mean, I commend them so much for doing what they needed to do to get the work done as far as collaboration goes, but even not giving up and continuing to push to meet that fidelity standard, because we know that there's reasons behind it.
Yeah, always asking the why. Like sometimes the counties, it sounds like it's similar. Like our employment vocational programs are separate from the mental health centers in the counties too. And it's always been a struggle to get that going and that partnership. And there's still a lot of there's there's a lot of different views on that. So when we dig back into that why of the fidelity, why do we want this integration to happen? Why do we want that person to actually sit on the treatment team? Um, because we can listen about, if we're starting to talk with the supervisors of the team and the leadership of the agencies that refer, and get those whys in there, then they can see the reason to have that employment specialist there, and it's a little more buy-in. There's examples of MOUs and integrated, contracts and that sort of thing that we can help them with. But if they don't have that why, um, and so many of that why is what those whys come down to, if the employment specialist isn't hearing about these scenarios of people in crisis or bored or needing something to do or whatever, they can't then suggest employment as an option. The clinicians aren't going to think about that in the forefront, most likely, unless that employment specialist is sitting there in front of them in those meetings. And those meetings are where those strategies to add services to the treatment team or treatment plan come up. So having that person right there is so crucial. And yeah, I think, knowing too, there's different philosophies out there as far as, nothing about us without us, with the peer movement and that sort of thing. And some agencies have really taken that to the heart of, we're not even going to meet or have a treatment team meeting without that person present. So maybe they have monthly meetings with a person, with their care team, but they don't actually have case staffing meetings. So there's some areas of Wisconsin here that have that, where then the employment specialists are like, well, they just don't have a meeting to invite us in. So so then they try to meet with that one, core meeting once a month with every one of their clients. So it's really tricky, and we do what we can. But the more we can get that leadership to kind of figure out those whys, then maybe they'll start, having a meeting. Or creating one. We also see, sometimes they don't have a benefit, or they don't see the benefit of inviting ancillary services, like employment specialists or housing people or even prescribers, and they just have the clinical, maybe case managers or therapists meet. So it's not a full rounded kind of treatment team of all these different people and components that support the person. And they, talk with them because they're contracted. So they're maybe not with HIPAA or IT or like all these different things. So it's not just, the executive level or the team supervisor, but it's also like, let's bypass this through legal. Let's make sure that we're, making sure all of these boxes are checked so we can make sure that employment specialists can sit in on the treatment team meeting. Yeah, I think I had another thought with that one, but it went away. All right. Other thoughts as far as like integration in general?
I was just going to piggyback off of what you just talked about. I always think it's interesting because it seems like the employment specialists are the people who see the client the most often. And it's just always interesting to me when they're not invited to the table, because they bring so much insight that can be helpful to those other providers.
Yeah, that's a huge benefit. And that's another why to share with those leaders too. Like, we see this, we can update you at real time. We just saw them yesterday or this week or whatever. And the other, that reminded me of the thought I just had. So one solution we've had in one area, which I don't know that it was a great solution, but a solution was the employment specialist team, the vocational team, ended up just creating a team, like a team meeting of their own, and then inviting the clinicians that had mutual clients. So they said, hey, we're going to talk about employment. We would love you to attend. So it was more of like a reverse treatment team meeting, if you will. They invited the DVR counselor, they had their clinical referring, they invited the whole treatment team who referred, but what ended up happening was that only the people that really referred a lot would attend. So the people that needed to be there, wouldn't attend. And then you're also missing the component of, they're not doing a whole case staffing of their whole caseload or talking about other clients that aren't part of the IPS program. So you're missing that piece of being able to talk about potentially referring people. So we couldn't give them credit for fidelity. But as fidelity reviewers would write reports and give recommendations, being sure to share that with leadership and say, here's the whys, here's what we recommend, here's why we recommend it. To increase those fidelity pieces. Sometimes that's all it takes for an agency to go, oh, I want that extra point. Well, what do we do? What do we do? And then you'll see more increased points because of those reports.
Stacy, I wanted to bring us back to something you said before about DEI. And, we heard our reporting on that demographic information, and we all on this call know that Iowa is pretty very heavy concentration of white, non-Hispanic population, but we do have a lot of others. And your comment about integrating that reporting with the footprint of your program and your population area. We've been thinking about that from the Aspire program and the CEBH leadership. I was wondering if you had any ideas on where to get that baseline information, and maybe if you do have sources for that you rely on in Wisconsin, if you could share those.
Yeah, that's one of the areas that we are setting goals on to individually by IPS program. So we're not right now statewide kind of looking at that, unfortunately, because we're changing our statewide tracking system, and finally adding that, the IPS code component. We don't have that to compare right now. So it's really agency level. And I know Milwaukee does a better job of it than probably any other county. So I could go back to Sam, the trainer there, and see, what specifics that they're comparing it to. I do know that through some of the technical assistance grants and things that I've been involved in, one of the recommendations is just get from the census, just whatever's available, online. You can Google search what in your area, in your city, in your, county, what that is. And that would be probably where to start, but it probably would just go to your agency's leadership of where they want, what they want to compare it to. Because you're comparing, sometimes if you just take the agency data, here's the population of people that are coming to the behavioral health services as a whole, so county behavioral health, but that might not match the local area census. So I would say census would probably be the more accurate where to go, but then also looking at how many people in that area have behavioral health, and then divvying up that percentage. So you might want to talk to a data person.
Well, we've tried.
Would be probably where you could go, but that's
and
tough.
One of the things that I would just highlight with that is we have found in some of our investigative work that even though a population is a very small percentage of the catchment area population, that population might have an overemphasis of individuals with mental illness or other disabilities. So even though my Native American population is very, very small, a very high percentage of those have an issue that my program would address. So just the census data that says I have 2% American
you have to dig
Indian
in further.
Whatever. So anyway,
with how many of those in those areas have that diagnosis, and then from there.
Well, anyway, that's not going to be. It's a tough egg to crack, and to get consistency across the state and across programs, as well as promote progress and help with progress. So anyway,
I think the first step is just to start tracking that you have the data, and then deciding what do you want to pull from that data and what goals then from there. So kind of taking a stepwise approach, getting a work group together, leader, who's going to be involved, that sort of thing.
Yep. Thanks.
The DEI, what do we call it? The DEI equity assessment that the IPS community, we kind of created this tool for providers to use, walks you through some of that stuff, where you create an actual equity team, and then from that team you can have work groups and create these goals and kind of work on things with the DEI tool. Then that can create a plan for your local area. So that's kind of how we're using it in Wisconsin right now. So each area might have different goals that they want to work on in certain parts of the state.
That totally makes sense. Is that don't know that we've looked at that tool, Iowa folks.
I will if it's not on the web, well, regardless if it's on the website or not, IPS or ipsworks.org in the library there, I can always send it out to, I have it, I can send it to you guys.
Send it to Felicia's. I don't know.
Yeah.
We have that's you guys had a thing at the IPS conference about that, didn't you? Okay, yeah.
Right.
Yeah, we've shared it.
Okay.
And I feel like it is definitely a tool that will help us get to where we need to go.
Yeah, what the feedback from my supervisors I've been getting is it's so overwhelming, it's so big, like it's something they kind of keep tabling. They have so many things to do. So I've been trying to incorporate in my quarterly one-on-ones with them, and then in our monthly supervisor meetings, we address it like each component. Like we're going through each component at a time, and then we're encouraging the supervisors just to pick one question of one section, even just to start. And like let's talk about that and like analyze your program for that one question, and then have a goal for the next meeting to maybe report out if you have like, oh, you're doing great with that, or hey, you know, our hiring process doesn't include blah blah blah. Yep.
Mm-hmm. Yep. Thanks.
All right, well, that's all I have, you guys. But you know, you can email me anytime. You're here for all employment specialists and IPS programs around the nation, apparently. So,
well,
my boss
thank
is
you
really
so
flexible.
much. Thank you so much for being here and talking to us. It's all such valuable information, and I appreciate everyone else being here in attendance today. Please see the chat for the survey, and we'll see you next time. Thank you. Have a great day.